Hello, welcome to another episode of Our Experience, and I am Jaron Chats. My co-host Kevin Walker is not making it today. Today I'm at the PalpMed conference, and this is the CMO of Tapestry Health, Hans Jenkins. Welcome.
Thank you. Thank you for having me here.
Absolutely. So Hans is working for Tapestry. He's doing a lot of work to change some of the directions that Tapestry has gone in the past.
Yes.
Just kind of give us a background on what Tapestry Health is.
So Tapestry Health is a service industry where we use AI as well as other advanced technology to help expand primary care in the long-term care space.
Right.
So we started initially as a kind of a rural nursing home telehealth company.
Right.
It started back before COVID. And then when COVID started, they found that the need was even more expanded.
Right.
And so as part of that, they found that there was not enough well-trained medical directors and other service APPs for the industry. And so they started to expand some of this technology. They brought in a company called Natera. And it has these little devices about the size of a cell phone that sit in the room. And these devices will pick up passive respiratory rate and heart rate, as well as how often the patient is in and out of bed. And so they use that and leverage that to kind of help predict as well as determine when patients were declining or they were improving. Same thing. So that's kind of where we're at now. I started a year ago, and now we're trying to expand that even more and take it to the next level where we're able to incorporate pharmacy, which I know you and I have talked quite a bit about.
Yes.
And that's one thing I think that people don't understand is that physicians are only as good as the tools they use.
Right. Good way to put it.
Yeah. And you're the tools. You're
right.
tool people, so to speak. No, you're not a tool. But
that's what I was going to ask.
You're the tools that we use, right?
Right.
That's the biggest lever we can pull is medications. And
Absolutely.
That's why I love working with Jaron. And it's something I know you went with Chess, 3 years ago? You tried to work on some stuff with their technology?
Yeah. So I've been familiar with Tapestry for a few years, and I worked with their prior two CMOs ago.
Yeah.
And I've always been impressed with the technology that you guys do and the vision that you guys have. And, it's often overlooked by a lot of medical providers that medication is obviously the biggest need for rehospitalizations and several other things. And so, it's great to see you kind of driving that forward when it's been stagnant for a very long time.
Yes,
so,
we're excited about that. Very much so. And, we're seeing the results, right?
Yeah.
Even now, before we're fully incorporated, we're seeing the results of what's happening.
Right.
And seeing patients' lives improve and seeing facilities to be able to use their, people power for more good, right?
Right.
Because be able to focus on where they're needed most. Because, we're getting more and more sicker patients in the long-term care facility. You and I worked together a decade ago. And then it was the patients weren't as sick as they are now.
Right.
And the funding is not increased. It's actually decreased, right? So now we're going ahead and expanding that with this technology and helping them still be able to provide good care with more demand.
Yeah. And you're right. They are getting sicker. They're getting on more meds. It's getting more complicated. When and I'll give everyone a little bit more context. Hans is also from Utah. And I don't know if you know this, but the very first home that I acquired under my own business was Heritage Park.
Oh, yeah.
And so that was the first home where you kind of let me kind of spread my wings and do all the stuff that I wanted to try that was a little different and innovative from what had been done in the past. And you just let me try it, and it worked out great.
Yeah. That building improved to a 5-star building. It went from a half-star, or if that, almost it was pretty rough shape, and it went clear up to a 5-star building in less than 2 years.
Yeah.
It was phenomenal with your help, obviously. That just goes to show a good example of how when we work together in a collective, things improve.
When you get all the team parts together and they're all functioning at a high level, it makes a big difference.
Yeah.
And, I can't take all the credit because, they were under new ownership and a lot of things happened there. So
new management and everything. Yeah.
Yeah. And I know another thing that I don't know if this happened before you arrived at Tapestry or if you were the one driving this forward, but I know you guys also changed from an outside team doing your CCM or chronic care management. You had maybe outside biller services, and you guys kind of brought that all in-house. So was that you doing that?
That was before that. So they decided to bring that in in 2024, I think, right before I got there. But so now they have everything in-house. And one thing I think that people should know is we do use AI the AI does not touch a patient without going through a human review first.
Right.
So we have over 1,000 reviewers who review all the information, all the data. The AI basically takes all the data from this continuous monitoring of vitals, takes that and compiles it in a readable form. Otherwise, you'd be doing minute by minute vitals for hours and hours and hours. And so, what it does is compiles it, looks at trends, and then the people review it, review the medications, review different things, then make decisions based on that.
Okay.
So the AI never touches a patient without going through a reviewer first.
All right. And so just what vision did Tapestry have with pharmacist services before, and maybe before you came on board?
Yes.
And what did you do to kind of course correct it or change it up a little bit?
Yeah. So they other than when you talked to Jess 3 years ago, they had not much of a pharmacy plan.
Mm-hmm.
And when I came in there, it was funny. Like, it was this first board meeting I was at with Dr. Chess and a few of the board members, and they were talking about how they wanted to probably expand on the quality of how we're recommending pharmacy changes and different things like that. Okay. I said, well, if I got someone for you. And so I said, I know this guy named Jaron. And Dr. Chess is like, oh, I know Jaron. We talked to him 3 years ago with Dr. Blackman. And
so that's how it happened.
Yeah, it's a small world. Right?
Yeah,
so I'm out in New York City at this board meeting in Manhattan. And they're like, we know this guy who's amazing at this. His name's Jaron. And I was like, oh, well, let me call him. So I called you like right after the meeting. I just gave you a call from that 15th story building. I was like, hey, Jaron, what's going on, man? So it's kind of funny how it's this really small world.
It really is.
What we did at the buildings you and I shared together, using technology to expand that. Because the hard part is when you have someone like yourself who's talented, has a great program, is using technology to expand you and your capabilities. Right. And that's what we're trying to do here. And that's our goal. And I think, a lot of great pharmacists in this community could benefit from that, to be able to expand their capabilities, to be able to get the information packaged for them so they spend less time in clerical work and more time using their brains to help patients. And that's the key. Okay.
So I'm just curious, what kind of issues arose that made you guys think, a pharmacist would be great here?
Oh, well, psychotropic to begin with.
Okay.
And even QAPI, right? Like you got people with antibiotic use, multiple antibiotics, medical reconciliation. You've got some of the sites I visited in California. Here in California, I flew out the second week I was here and visited some of our big clients out here. And some of the biggest tags they had was expired meds, refrigerator temperatures.
Oh, wow.
In California, just stuff like that, it's something that you guys do, right? As a service. And as well as that, psychotropic is a huge mess. I mean, It's a mess everywhere. And you've got so many hands in the pot. You've got, the Omnicares, and you've got these other pharmacies saying, we're going to provide, Prozac or whatever for this behavior. And you're like, this is probably not the best. Right. So like I remember, in Heritage Park, we had behavioral health as well as half the building was behavioral health.
Oh, yeah.
And dual diagnosis. And that was psychotropic there was difficult. And so even, when I came out and visited these buildings after that board meeting, I was like, man, this is something we could fix. It's something we could fix. I've done it in the past. I've seen it work well. And I've told one of the big clients here that, we got a building that was half psych to 5 stars. Like, no one does that. No one can get a psych building to 5 stars because of the nuance and the difficulty and,
Yeah.
And so I told them that. They didn't believe me. And so I said, hey, go look him up. Go talk to Alan, the CEO. And we did it. And and they did. And now they're like, hey, we need the services.
Wow.
So, and that's what I'm doing later this week too, is meeting with some of these buildings that have psych only long-term care.
Mm-hmm.
So they have dual diagnosis psych only. They got a bunch of buildings here in California and across the country. So they're like, hey, we want to, when you get this figured out, we want to, clone Jaron and send him out to 600 buildings, right?
A lot of people might find that scary.
Yeah, scary. But that's kind of what they want to do. They want to see that not only help the star ratings, but at the very end, focus on the patient.
Exactly.
The patient's quality of life, I think, improves in that situation.
All right. So, one of the visions that I've had since I started my own company 8 years, technically 10 years ago, but when I decided to branch out on my own and do it all on my own, one of my main visions was, in fact, medical directors walking into buildings and saying, let us provide your consultant pharmacist. And, to me, that felt like a lofty goal. And my vision was, okay, it'll take me 20, 25 years to get there. And now here we are talking, and now it's potentially going to happen with Tapestry in under 10 for me.
Yeah.
So, I mean,
it's
a huge deal for me. And I hope it's I know you guys are excited about it too.
Yeah. And that's why we're here at Pulp Med. We have the Certified Medical Director certification here. So you have a lot of the best medical directors in the country come to this convention. And the ones I've talked to, I've known for years. I've kind of given them a little taste of what we're doing.
Right.
They're like, when can you start? When can we get this tech? When can we get
Right.
this? They're like, when? Because that's a big initiative.
Right.
PulpMed is to help improve the patient care without increasing the costs.
All right.
And that's the
awesome.
key.
So I know we've also talked about improving transitions of care. What kind of stuff are we working on at Tapestry to improve transitions of care?
And the biggest problem with transition of care is someone comes out of the hospital, and what do they do when they discharge them? Return to home meds.
Yeah. Dump a bunch of meds on them.
And it's but then they're like, well, we want to keep, the anticoagulants. So they go home, but on the home meds, they also had aspirin or, whatever.
Yep. And
so they go home, and this patient, then the poor mom comes home, and the kid's like, oh yeah, they just said resume home medications, and as well as these 4 or 5 they get from the hospital, or sometimes 10. So that medical resuscitation is key. Right. I've seen so many patients, even family members come out and like, why are you taking, Plavix, and why are you taking, Eliquis, and why are you on also a baby aspirin, and then you're getting naproxen 3 times a day for your arthritis? Like, why are you on all this? This is so messed up. Like, this is not doing any good in your poor gut, right? So, and your kidneys. So that's the thing is, I think that's one of the biggest things is the transitional care management is making sure that those tools they go home with the hospital match what's on there. And it's just, it's a primary care doc and out in the community or a hospitalist, they don't always talk to each other.
Exactly.
And that's where technology comes in, right? Technology come in, gather the information from all the EMRs or all the visits they've had, and take that and provide a concise duplicate or whatever they've got going on with medical resuscitation to the pharmacist, the consultant pharmacist, and making sure that's corrected appropriately. Because the medical director doesn't always have time to come in and look at all that stuff.
Right.
And so with the consultant pharmacist, some things you can just fix. Right. And it speeds up time because you're not trying to find someone, they never discharge on a Monday afternoon, right? It's always a Friday afternoon at 4 p.m.
Right.
In a rural community where the pharmacies close at 5.
Exactly. All the time. Yeah.
Oh, my grandma needs this. Where are we going to go? Like, drive an hour away to Cincinnati and get, the 24-hour pharmacy or whatever.
Exactly.
And even now I run into that. People call me from my community and they're like, hey, because in my community, it's an hour to the nearest 24-hour pharmacy. And always on Friday afternoon, someone in my neighborhood or whatever is just saying, hey, grandma got sent home and we don't have access to this. Can you give it to support? So I got another 20-hour pharmacist, man. I don't know what you're doing. So that's the key. It's just, you have the book, the academics, and you have what really happens. Right. Right. And that's the key. That's one thing we learned at Heritage Park too, is the hospitals like to discharge for the weekend, and the nursing homes, because they know that's coming in. Those admissions are coming in. They like to discharge on a Friday. So you get this waterfall effect, and everyone's stuck. The poor families are stuck sometimes without the resources they need.
Yeah. And so what are the transitions that you're going to be focusing on more discharge hospital to home, or is there any other transitions that would be?
Well, yeah. I mean, hospital to home is a big one, but also sometimes even I've seen it when they discharge from the hospital to post-acute care or long-term care back where they came from.
Yeah, and then to ALFs, and then
and they did. I see all the time resume previous medications for because they were probably treated by a cardiologist, right? That's the big thing. And the cardiologist, there's no body system outside the heart, or a nephrologist. There's no body system outside the kidneys. And so they say stop these meds, resume the rest, and it's like okay, and you added some other stuff on there. So, and that's the key is those discharges sometimes, unfortunately, are not handled well.
Right.
And it causes problems at readmissions or,
right.
That's difficult, especially when the patient's, either a psych patient or cognitive can't really tell you what's going on, what they used to take. Right. That's hard.
And so it's almost like we're adding some connective tissue to all these, silos that historically have just been very isolated and not very communicative. We're just adding the tissue, that connective tissue that brings all these silos together, and so that they're all connected. And
absolutely. And that's the key. And even then, I mean, once we get that figured out well with our technology, is getting information back to the hospital.
Right.
So that's the key, is when someone is there and they're going to go to the hospital potentially for readmission or some decline, is some way to communicate back with the admitting physicians.
Right.
I know we did that at Heritage Park. We had some direct admissions back with one of the hospitals there. I don't know if you remember that too much.
I don't.
But we did do that with our post-acute care side, especially with behavioral health.
Right.
We had uni direct admissions for some of the people on that side. We go back to uni.
Okay.
That's one thing we worked on well. It didn't work all the time, depending on who the hospitalist was and who the administrator was that day. But a lot of times we could communicate, and I would call directly to the university hospital and say, hey, we received this patient a while ago from you guys. Here's what's going on. And so I would try to communicate with them or have my nurse practitioner communicate with them back.
Right.
But that's time consuming. This is a long time ago and technology years, right? And so the key is now that we have this technology and we have two-way communication, I've brought people onto our team who work with hospitals, work with their EMRs, and they're going to be able to make sure that if there is someone that potentially go back, they can send the information we've collected from our data, from the devices or whatever,
right,
and everything we've done with them, send that back in a concise form saying, here's what's going on, here's the situation,
right.
and what would you do?
So, most of the time when I think of transitions of care, I think of communications with the PCP.
Yeah.
But you're also talking about how it's also going to be communicating with the hospital.
It has to be.
So I've never thought of that, but now that you bring it up, it makes sense because a lot of times what we see is people are in the hospital, then they go to the skilled nursing facility, they're there for 2 weeks, then they get readmitted to the hospital, and the hospital doesn't even look at the meds that we sent. They just say, what were they on last time? So they restarted antibiotics. They restarted some stuff that
IV insulin will get restarted.
Yes,
even though their blood sugar is fine.
Yeah, like they don't even look at what we gave them. They're just like, easiest path is just so. Is that going to be resolved in this type of communication?
Yeah. That's you met Candace, one of our team members.
Oh yeah.
That's what her specialty is. She and I worked together back when I was at HCA, and she's set up EMRs for multiple hospitals.
Wow.
So she's a consultant that's going to kind of work on that communication because the hospitals want it, especially for these MA plans. They have the bundled package, right?
Right.
They pay the hospital for that admission. They come back. They're basically treating that patient again for free.
Wow.
And it's cost expensive. So they're hungry for it.
Yes.
And they reached out to me for that.
No kidding.
And so, my friend reached out to me, and so I said, well, I got a deal for you. Like, we're working on this one-way communication. So now once we've got it that way, we can go back to it.
Right.
Which shouldn't be an issue, right? Once you have it. Because we're already collecting it. We have the database. We have everything we need. And we have the AI to recommend, hey, here's what's going on. Here's our AI recommendations. Here's the reviewer's recommendations. Like, what do you think? Because the studies show about 25% of readmissions, roughly.
Right.
The most recent studies show that they're preventable.
Right. Yeah.
But even those 75% that aren't preventable, the hospital stay will be shorter if they have good communication from the facility.
Right.
Because then they know what they're on. There's no, less chance of a complication, and they'll come back quicker. So that would save a lot of money too.
Yeah.
So that's our goal. Again, is trying to keep those resources available to patients who need it.
Right.
So,
and there's a lot of stuff in healthcare, and data shows a lot of, that there are a lot of things that happen that are preventable. And until we utilize better technologies, until we utilize improving our staffing of healthcare, those are two key components that I think will improve preventable care. And I know you talked earlier about the technology, and also want to clarify for everybody that Tapestry is a technology company.
Yes.
And they're kind of like I like to tell people they're like the Tesla of healthcare.
Yes.
Tesla's not they're not an automotive company. They're a technology company that makes cars.
Absolutely.
So, and you're a technology company that provides healthcare. Yep. And so, you mentioned earlier the machines that go in the rooms and monitor their residents and whatnot. So what other technologies is Tapestry kind of?
Yeah. So the big technology, again, is database management and managing the data we collect either from those or data we collect from the EMRs. Right. We have several EMRs we can push through our database and kind of gather information. Like, when was the last time they had a GDR? What was the PHQ-9? What was the GAD-7? We can scrape that data with the AI and bring that into the reviewer. So not only have our machine, but we have this other machine that goes out and basically gathers all information it can find. It's so cool. It can recognize cursive. It can recognize PDFs. And it just gathers that data. And it's just so fun to train that device. We call it Tapestry Complete, is the other technology that actually gathers that. It's fascinating what it can do.
Yeah.
I mean, some of the stuff our beta testing now can not only tell the patient, what they're at risk for, but also if they've ever been readmitted at any time in the information we have, access to whatever data we have, it will tell what caused the information, what their vital signs before they admitted.
Wow.
So we're beta testing that, but that's going to be that thing about going back.
Right.
So last time they had like a COPD patient, last time they had this decline, we had this intervention in it at the hospital. It worked. But in that case, when we looked at, the intervention could also be used in the facility.
Right.
So now we have this AI saying, hey, last time all we did is this, he got better. And so with that, theoretically, we're still in the testing phase, but you could tell the facility, hey, we can treat it in place because it worked for this patient last time.
Right.
And it's even if they're a different nursing home, as long as they're tied to his, Medicare number, we can find out what happened in the past at the hospitals.
Right.
So it's pretty fascinating. That's stuff we're working on, and that's why we're excited to have you here working with us as well.
Yeah.
I appreciate this. I got to.
I was going to say, I want to be respectful of your time.
I'm a cabbie today. Running back to the airport. So, because with the TSA stuff.
Yeah, and these conferences is always a go.
Yeah.
So
appreciate it so much.
Yeah, thank you. Well, you have and enjoy the rest of your time here in California.
Thank you. You too, man.
We'll see you.